Crohn's disease. Etiology, pathophysiology, and pathology. The etiology is unknown, but there is a presumed autoimmune process, association with paranuclear antineutrophil cytoplasmic antibody and antibodies to Baker's yeast. There is a measurable genetic component, with family studies showing 50% concordance in identical twins and linkage studies incriminating a number of loci. There is also a possible association with infectious agents, e.g. Mycobacterium paratuberculosis. There is an increased incidence in cigarette smokers. The characteristic histological features are transmural inflammation with ulceration and granuloma formation, Fig. 47. This may affect any part of the gastrointestinal tract, mouth to anus, but predominantly the terminal ileum, right colon, or rectum and perianal region. Affected areas are often separated by normal bowel, skip lesions. The process may cause strictures or fistulae to adjacent structures and is usually accompanied by a vigorous systemic response, with raised C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR. Epidemiology. Incidence is 6.8 per 100,000 and prevalence is 26.56 per 100,000 in Northern Europe, the USA, and Australia. Slightly more common in females. There is a bimodal age incidence, 15-40 years is most common with a second peak at around 70 years of age. 10% of patients have a first-degree relative with the disease. The risk for siblings is 30-fold increased compared with the general population. Smoking increases relative risk 3-fold. Clinical presentation. Common. Diarrhea, abdominal pain, and weight loss, often greater than 10% body mass, are all expected, with Crohn's disease the presumed diagnosis in a young patient with this triad. May be associated with general malaise, lassitude, fever, and anorexia. A careful history may reveal a lengthy preceding history of bowel upset, a previous diagnosis of irritable bowel syndrome, or previous perianal disease, fissure or abscess. Rare. Occasionally mistaken for anorexia nervosa. Physical signs. Common. There may be few physical signs, or the patient may be thin and unwell with clubbing, aphthous ulceration, abdominal tenderness, and perianal skin tags, ulceration or fistulae. Uncommon. Abdominal mass. Rare. Fistulae, seronegative arthritis, sacroileitis, iritis, and skin rashes, erythema nodosum, pyoderma gangrenosum. Investigations. Blood tests. FBC often shows anemia, which may be normochromic, normocytic, chronic disease, or result from iron, B12, or folate deficiency. The platelet count is often high in active disease, regarded as an inflammatory marker. Serum inflammatory markers are raised, CRP and ESR. Serum albumin is often low, due to chronic inflammatory disease process, not malnutrition. Vitamin B12 may be low due to terminal ileitis. Other tests. Sigmoidoscopy and colonoscopy can show colonic or ileal inflammation, may be patchy, granulomas on biopsy and is the investigation of choice. Small bowel follow-through can show segmental inflammation, strictures, and fistulae, Fig. 48. MRI scanning is particularly useful for assessing complex perianal disease, including fistulae. NB. Rectal biopsy in Crohn's disease may show granuloma even when macroscopically normal. Differential diagnosis. Ulcerative colitis if colonic involvement. Abdominal tuberculosis, particularly if terminal ileal disease and the patient is in an at-risk group. Malignancy and intestinal lymphoma. Treatment. Emergency. Patients who are very ill will require emergency admission to hospital for resuscitation followed by treatment. Short-term. Corticosteroids. In severe disease, start hydrocortisone 100 mg for QID. Following clinical response, or if the attack is less severe, commence oral prednisolone at 30 to 40 mg daily and taper down by approximately 5 mg per fortnight depending on clinical progress. 70% will be in remission in 3 to 4 months. Budesonide, a topically acting steroid with high potency and extensive first-pass metabolism, is equivalent to prednisolone in inducing remission in terminal ileal disease and has fewer side effects, but is much more expensive and relapse rates within 1 year are disappointingly high. 5-aminosalicylic acids. These compounds have only marginal benefit in acute disease. Dietary. Elemental and polymeric diets containing low molecular weight nutrients may induce remission in up to 70% of patients, particularly in small bowel disease. They need to be taken cold as a sip feed and may have to be given by nasogastric tube, for 6 weeks. Other. Metronidazole or ciprofloxacin may be useful in treating perianal sepsis, but the evidence for this is not strong. Long-term. About 50% of Crohn's disease patients will have relapsed 1 year after initial treatment. 5-aminosalicylic acids have at best a modest effect in maintaining remission, with the post-surgical subgroup benefiting most. Azathioprine. This immunosuppressant has been shown to induce remission in steroid-resistant and steroid-dependent patients, to reduce relapse rates, including post-surgery, and to have steroid-sparing effects. It takes 6 to 12 weeks to achieve its effects. Side effects include bone marrow suppression, liver dysfunction, dose-dependent, and pancreatitis, idiosyncratic. Patients should have FBC checked weekly for the first month, then monthly for 2 months, and 3 monthly for the duration of treatment. Methotrexate. In those intolerant of, or failing to respond to, azathioprine, methotrexate may be tried. In steroid-dependent patients it has been shown to achieve both remission and withdrawal of steroids in 39% compared with 19% given placebo. Infliximab. This anti-tumor necrosis factor, TNF-alpha antibody is established in the treatment of refractory Crohn's disease. It may induce long-term remission in up to 60% of patients and has recently been licensed for maintenance therapy, although it remains very expensive. All patients should have a CXR to exclude previous tuberculosis prior to starting treatment. Surgery. Crohn's patients have a 90% lifetime risk of surgery, Fig 49. Indications include failed medical therapy, abscesses, fistulae, intestinal obstruction, and hemorrhage, and in limited terminal ileal disease it may be considered the treatment of choice. Half will have symptomatic relapse within 10 years following surgery, although up to 80% may have evidence of disease at endoscopy, but not all will require further operations. Stricturoplasty may be performed, rather than resection, to preserve small intestinal length. Complications. Common. Intestinal obstruction. Usually subacute. May be due to active disease causing edema and narrowing, or to chronic fibrotic stricture. The former usually responds to steroids. NB. Patients with small bowel strictures are advised to maintain a low-fiber diet to avoid food bolus obstruction. Malabsorption. Vitamin B12 deficiency and bile salt diarrhea are caused by terminal ileal disease. Extensive involvement of the small bowel or surgical resections result in generalized malabsorption, short bowel syndrome. Bacterial overgrowth secondary to enteroenteric fistulae or strictures results in fat malabsorption. Perforations. Contained perforations result in abdominal, pelvic, and ischiorectal abscesses and require drainage. Uncommon and rare. Chronic blood loss causing iron deficiency anemia. Massive rectal bleeding, almost always secondary to colonic disease. Toxic megacolon can occur, but is less common than in ulcerative colitis. There is an increased risk of colonic carcinoma in patients with colonic Crohn's disease. Free perforation is rare. Prognosis. Morbidity. Some patients experience considerable morbidity from general ill health, pain, malnutrition, fistulous disease, abscess formation, repeated surgery, or steroid side effects, but most are maintained relatively symptom-free. Mortality. Overall mortality is twice that for the general population. Those diagnosed with the disease before the age of 20 have more than 10 times the standardized mortality ratio. Prevention. Cessation of smoking is of benefit in active disease and reduces the risk of relapse. Disease associations. Weak association with primary sclerosing cholangitis, arthralgia, and arthritis, also with HLA-B27.